Good morning and welcome to this Australian Centre for Value-Based Healthcare webinar. I'm Lisa Roby, the Engagement and Business Director at the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host today. Before we get underway, I'd first like to acknowledge and pay respects to the traditional owners of the lands on which we meet, wherever we may be. And to pay our respects to elders past and present. I also extend that respect to Aboriginal and Torres Strait Islander people joining us here today. Today we're joined by Dr. Sally Lewis, National Clinical Lead for Value-Based and Prudent Healthcare in the NHS Wales. Often when we hear people talking about value-based healthcare, they come from the hospital perspective. Sally has frontline experience of primary care at its most challenging, both as a GP and from when she rebuilt a struggling GP practice into one of the most successful in South East Wales. Her career in medical management has led her to focus on value-based healthcare, and her current interests include the utilisation of value-based principles to allocate resources in publicly funded systems, patient outcome data, and digital transformation. Sally recently authored an opinion piece for the Value-Based Healthcare Focused edition of AHHA's peer-reviewed journal, the Australian Health Review. In it, she outlined some of the concepts that inform value for patients and value for the health system, and how value-based healthcare can inform relationships and drive investment or disinvestment. Today, she'll be talking to us about how value-based healthcare can meet the evolving needs of the population and challenges encountered during the phases of policy and implementation. Sally has kindly agreed to answer questions at the end of her presentation, but don't feel you need to wait till then to ask. If you have a question, you can type it in using the Q&A section you'll find at the bottom of your screen, and we'll work our way through the questions at the end of the session. So with that housekeeping out of the way, I'd like to pass over to Dr. Sally Lewis.
Thank you, Lisa, and hello everyone. It's a pleasure to be here. So what we're going to talk about today is how we've been thinking about value-based healthcare in Wales, which is an integrated healthcare system, and how we've been applying value-based principles to try and achieve some of the aims that I'm sure you're trying to achieve in Australia as well. We have a population of 3 million people across Wales. It's a publicly funded healthcare system, so we don't have a significant private sector like you do, but I hope that you'll be able to see how we can apply value-based healthcare principles to meet the whole system needs of your population. So, about 5 years ago, the then Cabinet Secretary for Health in Wales launched a policy initiative, a philosophy really, called Prudent Healthcare. And this was in response to many conversations which I know have also been happening around the world, that there's an unease that we have, that we're not really delivering what we need to deliver in the healthcare system for our patients. We've got sustainability problems, we've got issues of poor patient experience, and we don't always achieve the outcomes that we would want to for our patients. And there's a sense also that sometimes we don't direct resources to where that they have the greatest impact. So Prudent Healthcare had 4 principles. The first was really talking about co-production and how do we work with the population and with patients, both at a macro level in co-designing services, but also trying to co-create individual health solutions as well, so bolstering shared decision-making in the consultation towards shared understanding of medicine and better choices for patients. There's a strong push towards promoting equity and really trying to care for those with the greatest need first, and avoid harm through, including through overdiagnosis and treatment, and getting staff also to work at the top of their licence so that we were really maximising the skills that we had in the workforce, and of course tackling unwarranted variation. One of the difficulties that we had with Prudent Healthcare was that it was quite abstract and philosophical and very difficult for people to grasp onto and deliver. and we needed also data to help us to see what progress we were making against these aims. And so we came across value-based healthcare and really started to view that as a delivery mechanism for the aims of prudent healthcare. So how do we look at value in an integrated healthcare system? Well, as many of you know, Michael Porter in Harvard Business School has described value-based healthcare with his colleague Elizabeth Teisberg. And Michael Porter describes value as the outcomes that we get for the costs that we incur for those outcomes. But of course, we need to measure those costs of care over the whole care cycle and the outcomes. And the outcomes are defined as outcomes that matter to patients. So it's perhaps not the sort of outcomes we would have traditionally thought about. So it's things like, have you resolved my pain? Am I able to work? Am I able to play with my grandchildren? Can I sleep? What are my quality of life like? As well as, of course, the clinical outcomes in terms of, you know, has my tumour shrunk if I've had chemotherapy? So the clinical outcomes must be married with the patient-reported outcomes. And value, therefore, as you can probably see, cannot be delivered by a hospital on its own or any other institution on its own. It has to be seen in the context of a whole system or from the point of view of a patient or a population of patients. And the other thing we're interested in Wales, because of the way we allocate resources across the system and because of the way our system is financed, how do we make sure that we allocate those resources for maximum impact between disease programs, between systems in each program, and also between interventions within each system. So a little bit more on that later. I'll give you an example to illustrate that point. So what we're really trying to do is find the sweet spot between investing in medicines, investing in staff, the people that are looking after our population, and new technologies like the robot you see in the picture. And we don't do that, do we? We do tend to default towards new technologies and perhaps don't invest as much as we should in some of the very high impact but low cost, sometimes seen as softer interventions, which really do have a very big impact on patients' quality of life. So this is an example of how we might start to deliver value across a whole system. This example is for a population of patients with heart failure. So obviously, if you're wanting to deliver maximum value to heart failure patients or a population at risk of heart failure, you have to bring prevention into the equation and start to think about what we're doing to prevent cardiovascular disease overall. And then, of course, we need to move into how do people recognise when they're ill and how do we get early and accurate diagnosis. But how do we not overuse the precious resources that we have in echocardiography, for example? So are we optimising how we are using echocardiography, making sure that we're screening out people who perhaps don't need an echo wherever that's possible? And then we have to optimise the intervention, whether that's through medicines, devices, or psychological support for patients. And the other thing to note is that if you're looking at outcomes for patients, some conditions are not curable. So getting a good outcome in that context also means quality of life as the disease progresses, and enabling people to have a good death, the death of their choosing in their preferred place of care as well. So this is truly a whole system endeavour. And I think what this illustrates is that certainly in our view of value-based healthcare in Wales, this is not about improving outcomes through competition. This requires intense collaboration across the whole system if we are to achieve sustainability outcomes for our patients, and also give patients a good experience of their care. So we have to see the bigger picture. And I don't think we always do that. Often patients tell us that their experience of care is very fragmented, that there's poor communication. And I think that sometimes as clinicians and people working in the healthcare system, we become very very service focused, and we just see that one piece of the jigsaw puzzle. So what we need to do is really start to join this up and take that helicopter system view. So how do we generate value, and how do we allocate resource across the system? Well, here's an example in chronic obstructive pulmonary disease. If you look at value based on the evidence of cost effectiveness in COPD, based on current evidence and using the cost per quality adjusted life year, we see that the lower cost per quality, so arguably the highest value interventions which we should maximise first of all, are smoking cessation, flu immunisation and pulmonary rehabilitation, with inhaler therapy costing a lot more per quality. So that doesn't mean that we shouldn't prescribe inhalers, of course, but it does mean that we should be maximising the investment in the high value, lower cost per quality interventions further down the pyramid. Because if we don't do that, we won't get highest value for patients and we won't get the best outcomes. So you would imagine that if everything was working correctly, that we would maximise our investment at the bottom of the pyramid. But actually what we often see is the opposite. And this was based on an analysis in my old health board where we looked at spend on inhaler therapy and variation in spend across Wales and across the UK, in fact. And what we found was that we were extremely high cost prescribers. We had the highest expenditure on inhalers for COPD based on our prescribing data of anywhere in the UK, in fact. And that didn't match up with the prevalence or the outcomes that we knew about, like hospital readmissions for COPD, for example. And yet we had significantly underinvested in pulmonary rehabilitation, which has a strong evidence base around preventing hospital admissions. So armed with that knowledge, we were able to start a collaborative conversation with clinicians, managers, pharmacists, patients and financial managers to figure out how we could rebalance that investment. And that's tough work, you know, it takes some doing. But my clinical colleagues were very engaged with this because what they knew was that the hard work around rationalising inhaler prescribing meant that they would be able to reinvest any savings that they had made into pulmonary rehabilitation for their patients. And that's exactly what we did. So this concept of rebalancing the system from low value expenditure to high value expenditure is very important in our system and in an integrated healthcare system. So we should imagine, shouldn't we, that evidence-based medicine over the last 20-25 years should have sorted this out for us. If we were only doing evidence-based practice, then we would not have issues of low value care. But as you will know, there is still quite a lot of unwarranted variation in care, and frequently the second part of David Sackett's original definition of evidence-based medicine is often omitted. So over time, whilst evidence-based medicine has taken us great strides in standardising care and enabling us to create guidelines, we have arguably created also a tyranny of single disease guidelines which don't take into account the context of the individual patient. And the other problem with evidence-based medicine, of course, and with single disease guidelines is that randomized controlled trials are the gold standard of evidence, but they frequently have exclusion criteria that are such that they exclude many of the people that we will subsequently want to use the treatments in or apply the guideline to. So we are often arguably inappropriately extrapolating evidence to other people within the population. And because we don't measure outcomes, we don't know what the effect of that is. So here's Voltaire, my favourite philosopher, and 300 years ago Voltaire said that doctors pour drugs of which they know little to cure diseases of which they know less into patients of whom they know nothing. Now, evidence-based medicine has hopefully brought us on a little bit further than in Voltaire's time, but he has a point still, and we still know very little about the impact of what happens post-adoption after RCT, and the consequences of not knowing the outcomes that patients are experiencing are that we don't know multimorbidity effects. So as I hinted on the last slide, we're extrapolating evidence beyond its original scope. So what is the impact on patients with multimorbidity? What is the patient's preference and context? It's quite difficult to know what is unwarranted variation and tease that out from warranted variation if you don't know what the patient outcomes are. People want better information to make decisions and choices about their care. So for example, if you're deciding whether or not to have third-line chemotherapy, you may wish to know, based on outcome data, what the likely trade-offs are going to be for someone like you between quality of life or length of life, for example. So if we were able to collect outcomes and collect a reasonably sized amount of information, we would be able to start to reflect that back to patients. And also, we have no way of objectively knowing how people are getting on at home. So as a clinician myself, I know that if I'm worried about somebody or I don't know what's going on with them, I want to bring them back to the surgery and see them face to face. That creates capacity issues and access issues in my surgery, and isn't always necessary, and the patients don't necessarily always want to come and see me. So can we use outcome measurement as a structured communication about a patient's status to start to drive new models of care? We think so. Therefore, the vision for value-based healthcare in Wales is this: to improve the health outcomes of the people in Wales in a financially sustainable way, but through the creation of a data-driven system which seeks to provide timely information to citizens, clinical teams, and organisations to inform decision-making. But before we get to the data, this is very much about changing the culture and changing the behaviour in the Welsh NHS and beyond, and that is everybody's business. And if we're to achieve transformation of our old models of care, which were developed for a population with a very different set of needs, and also in a time where there was fewer medical technologies, so we do not have huge caseloads of people living quite a long time with chronic disease. If we're going to transform our services to meet that need, then we need to work collaboratively, and clinicians and patients need to work hand in hand with financial managers and managers to help us to undergo this intense period of change management and to help us allocate financial resources appropriately. None of us can shy away from this endeavour if we're to address the real sustainability issue that we face globally in healthcare. So changing that behaviour is everybody's business. So therefore, at the beginning of the value-based healthcare programme in Wales, which initially started in One Health Board, but now over the last year has expanded nationally, the first thing to tackle is language, culture and behaviour within the system to get everybody behind this endeavour. So it's really got to start off as a grassroots project movement, not a top-down endeavour. You do need policy support later on, because when you're going to scale up some of this change management, you need resources and you need policy direction. But it's important to win the hearts and minds of clinicians, financial managers and managers within the system with patients, and just get going with some early building blocks of value-based healthcare in your region. And probably when I started this in the Aneurin and Bevan Health Board, which was the health board in Wales where this began, actually there was probably about 12 months of just having those conversations and starting to get those concepts across, excuse me, before we really got going with any projects. And that was time well spent. But if you have more champions, you could probably accelerate that process. So once you've got a core group of people who are bought into this idea, you then need to set to the task of embedding value-based healthcare within your organisation and your system. And to do that, you need to start to figure out how you're going to measure outcomes and capture the use of outcome data in the everyday care of patients. How are we going to measure costs? So the Porter model recommends time-driven activity-based costing very heavily. That's quite a labour-intensive endeavour, so we found that we are using a blend of patient-level costing, prescribing costing, a little bit of TDABC, different mixed methods of costing depending on the context. It's horses for courses really, and deciding why you need certain costs. What are you trying to achieve? And then, of course, you need to have an informatics and a data strategy to go along with that. And from an implementation perspective, the two hardest things are the change management, because this is a big change for the way we work in health, and the IT. And then the last part, of course, is if you build all of this infrastructure towards value-based healthcare and you start to generate data to help you make those value-based healthcare decisions, that's all very well unless you have a transparent decision-making process. You're not going to make any progress unless you can start to make value-based decisions. So that's the purpose of my value-based healthcare roof on the house there. So when you start to think about your data in relation to value-based healthcare, the biggest gap that you're likely to find is that you have not been collecting patient-reported outcomes. Patient-reported have tended to be used in a research context, or have tended to be rather costly and laborious to collect. So we have to find a way to make this not a laborious exercise. And basically the way to do that is to embed that in the direct care of patients and clinicians, which does require a cultural change in both patients and clinicians, so that this becomes an expected activity. And it must not impinge on the clinical time or make the flow through a clinic worse. So the best way to do that is actually to enhance the electronic communication with patients, because that's what facilitates data capture. And that can be done via mobile phone. That's been the most effective way that we've found to do this. And actually, if you get that communication right, you can allow large-scale semi-automated collection of patient-reported outcomes. You won't get 100%, so what we have found is that you can then increase the response rate by collecting the remainder of the outcomes in clinic or by other means, but that makes it much more sustainable if you can get that large-scale semi-automated collection by texting people at prom. Data visualization and accessibility of that information is then really, really important. There's no point creating a data black hole. That won't be meaningful for patients and clinicians. They want to know and use the PROM in the consultation immediately after capture, because use of it in the consultation has value in itself, even before you think about data. So unexpectedly, in embarking on this exercise of patient-reported outcome collection, we discovered that the most important thing, unsurprisingly, was enhancing electronic communication with patients. And this unearthed another possibility for us, really. Patients tell us that navigating their way through a fragmented healthcare system is rather like herding the sheep in the picture on the left-hand side here. And they really, navigating the system becomes a full-time job for people with multimorbidity. So how do we give power to the patient? Well, of course, if you have really good electronic communication with patients, you can then start to do a range of tasks with them that transcends boundaries between primary and secondary care. So they can start to manage their appointments with you, book and cancel appointments as they may do for other services. It enables the patient-reported outcome tracking, as I've already said, and helps us start to overcome information governance issues as well, because you can link that then to patient access to their medical record, which then can be linked to them sharing that record with whomever they choose, and enabling sharing information between healthcare providers. It enables flexible access to clinical advice so that you don't necessarily need to have your multiple sequential outpatient appointments in the old-fashioned way. And once you get wizzy at that, you can start to link in wearables and other tools to manage chronic disease remotely. So how might we use patient-reported outcomes once we start to get data coming through? Well, the other thing we found is that it's really important to make sure everybody is aware that an outcome is a milestone, an endpoint, or a consequence which matters to a person. It's not always an endpoint. It's essentially a point in time status of a patient. And that's really important because the rich use of PROMs is much more than just assessing an effectiveness of an intervention or the effectiveness of an institution at managing a condition. That's not really the best way to think about PROMs. And there are also nuances between how we might use PROMs in cancer, in episodic care, so for example, cataract surgery or other surgical pathways, and in chronic non-malignant disease. So at an individual level, so in the consultation, it's really helpful as a symptom tracker. So the KCCQ is the Cancer's Cardiomyopathy Questionnaire, which we use in heart failure, and enables patients and their clinicians to track their progress over time. That's really useful because it can act as triggers for key conversations, such as advanced care planning, if you start to see a deterioration in that trajectory over time, and therefore helps to promote shared decision making as well. When you aggregate up PROM data, if you can link it to clinical and other data, you can do quality improvement exercises and improve through comparing with other providers. But we have to remember that the things that drive variation in outcomes are not just about the healthcare interventions that are happening within an institution. They're much wider than that, and some of them sit outside health. So things like poverty, education, and other factors are impacting on outcomes. So I think we need to be very careful when we are thinking about competition between providers, and this also has implications for outcomes-based commissioning, bundled payments or payments by results. So just a word of caution around comparing outcomes for that purpose. It is, however, fantastically useful for identifying unmet need, which I will show you in a moment, and for adopting a flexible approach to caseload. So some of our clinicians in Wales are starting to remotely follow up chronic disease patients. So for example, people with inflammatory bowel disease who may not want to come to the hospital, they're often working. If they're stable, they don't want to come up, but we can establish this two-way communication that is supported by that structured communication of the patient-reported outcome. So you have the status of the patient in front of you, and it's helping us to identify unwarranted variation across the system and to begin the process of generating real-world information and real-world evidence to augment the evidence base that we already have. So to do that, of course, we need to have a national data strategy and an informatics strategy, and we have that too in Wales. So currently the national data resource is under construction, and this is essentially a way of us sharing and linking data with using common standards that we can share and use securely within Wales, within the Welsh NHS. So this is going to be a fantastically powerful vehicle for generating intelligence for us for how we should manage our healthcare services across Wales. What does the NDR look like? You can see at the bottom all of the sorts of data that will flow into the NDR. Which is basically all health generated data, no matter what system it's on, and that will go into the national data store from which we can start to do analytics. So what's our approach to deriving information from data? Well, from the perspective of value-based healthcare, the first thing we need to do is develop some standard reporting products. So the standard reporting products we're looking at are outcome data dashboards, which may be condition specific, and I'll show you one in a moment. Another standard reporting product would be an in-clinic PROM visualization, so that the clinician and the patient can see what that PROM looks like graphically perhaps and see trends over time. So these are things that we're building into our systems and which people will be able to access. And as the NDR becomes more effective, we aim to be able to populate these products in with as real-time data as possible. There are also, of course, other standard reporting products which help us on the value-based healthcare journey in Wales, such as costing data displays that my colleagues in the finance delivery unit in Wales were working on. And of course, we have lots of other data in the system that we probably haven't been using as effectively as we might, such as service spend data and variation data, the Atlas of Variation in Cardiology, health maps, prevalence of disease, that kind of thing. So from these standard reporting products, we can then start to generate questions and insights to inform decision making at multiple levels in the system, beginning with that one-to-one care and moving up through services, programs to support people with individual conditions and multimorbidity, and then up to organisational and big data research. But I think the point that's really important to hit home is that you cannot approach this as a data collection exercise in its own right. We have to enhance that communication between patient and clinician and make sure that the data that we generate happens as a byproduct of everyday care. If you're setting out to just collect data, you will never be able to scale it up and it won't be sustainable or meaningful for anyone. So we have a program of visualization best practice going on in the value-based healthcare program. We use Microsoft Power BI to do this at the moment, and this is the prototype that we initially developed on lung cancer, but we're now expanding that into other tumour sites, cardiology, heart failure, some of the planned care specialties like cataract surgery and hip and knee arthritis, inflammatory bowel disease and stroke. So how might we start to use PROMs? I wanted to show you this slide to emphasise the point about using PROMs as a needs assessment and really starting to tell you how you might improve your outcomes and at the same time improve the sustainability of your healthcare system. So heart failure, as you know, is a progressive condition with profound effects on a patient's life. The Kansas Cardiomyopathy Questionnaire tracks a number of symptoms, and I've got a few on here to highlight for you. So the first one is that we see with all chronic diseases in which we're measuring PROMs a very high incidence of mental health problems and depression. So we've seen anything from 30% up to 50% of people with a chronic condition will be triggering on their depression score. So that's important because we know that people with mood problems are less able to cope with their condition and more likely to require more frequent hospital admission and have greater healthcare utilisation and greater levels of distress. Also interesting, two of the symptoms that are tracked within the questionnaire are patients report swelling in the morning and patients report sleeping sitting up. And patients are asked to self-report how many times in the last fortnight have you experienced these symptoms. Now, for the most severe score, patients are reporting that they have these two symptoms every day in the last fortnight. Now that's extraordinary because actually what that shows then, if you look at the bar charts, is that around about 15% of patients have these symptoms every day, and that means that they are at risk daily of acute decompensation and hospital admission. On the flip side, about 2/3 of patients are stable. They don't report having these symptoms of uncontrolled heart failure at all in the last 2 weeks, so they are completely stable. So this is very helpful information in working with teams who are supporting heart failure patients in the community, so in our case our community heart failure nurse specialists, to help them understand how to manage their caseload and utilise their resources in the most effective way, rather than a one-size-fits-all approach. And it also identifies that cohort that may benefit then from involvement of palliative care and undertaking advanced care planning and so on, so that they're not bouncing in and out of hospital, and that they are, as they approach end of life, being able to be managed in their preferred place of care. So if you start to put PROM data like this alongside other data like deaths in hospital from heart failure, readmission within 30 days for heart failure, things like that, you can start to see how you can take a value-based approach to heart failure patients in your community. This is just an illustration really of tracking of PROMs for an individual patient. It's quite a nice representation. We've got three, it's an artificial representation. We've got three patients represented on here. One is stable in the blue, one is moderate, and then you've got your severe patients in the grey at the centre of the radar chart there. And so you can see how people are, how their symptoms related to their heart failure are changing over time, and the relative change over time. So very useful for patients to be able to self-track that, because you don't necessarily remember how you were 6 months ago. This gives a more objective view of that, so very, very useful. Here's another way you might use the data. So I mentioned earlier on about the nuances between how you may look at value and use data in chronic disease like heart failure. This is an example from patients with total knee replacement in Wales. And what's been done here is that an analysis has been done of the Oxford knee score, which is the patient-reported outcome measure we use post-knee surgery, post-joint replacement surgery in Wales. And that's been put alongside the type of prosthesis used, so the type of implant used, And what we see here on the funnel plot on the right is that we have a clear outlier. So implant number 4 has a significantly lower improvement score than the other prostheses, and it also happens to be the most expensive. That's not shown on here. So you can start to have some really interesting discussions with colleagues around, well, you know, what's the purpose of using that prosthesis? Do we need to disinvest in that if it's a lower value product? And that's interesting, because that's often the case for medical devices, that we don't know that when they are adopted, you know, following getting their kite mark. So to summarise, what are some of the generic factors that we might want to look at to generate value across the whole system and to help us integrate care as well? So from a patient's perspective, we're wanting to raise health literacy. We're wanting to, for example, use the digital tools to start to get people to interact with the healthcare system in a very, very different way. Support healthy behaviours towards prevention, of course, where prevention is possible, and support that shared understanding of medicine towards the best choices, so that when you go into a pathway as a patient, you're not just being put into a sausage machine of care where all of the interventions become an inevitability, but you are absolutely involved in understanding what each of those interventions is going to do for you and with you to achieve your goals and the outcomes that you need to achieve. That's our goal in Wales, and is an ambitious endeavour. So on the healthcare side, clearly we still would like to reduce unwarranted variation in care and low value care. So you may have seen some interesting analyses institutionally which estimate low value care as being around 20% of the healthcare that we deliver, and that's pretty consistent around the world and probably an underestimate. And we won't know the full extent of that until we start measuring outcomes much more systematically. Optimum positioning of drugs and devices. That's really, really important. So nobody's saying that we should be disinvesting in expensive drugs or expensive devices necessarily, but we do need to make sure that they're being used and benefiting the people who are most going to benefit from them, and not putting them in people who are not going to benefit from them. So if you put those two factors together, the unwarranted variation and the devices, and I could tell you that in the Atlas of Variation in Cardiology in Wales, we saw a huge variation in implantable devices for people with heart failure, so resynchronization devices, and your likelihood of getting a device was entirely related to your geographical proximity to the tertiary centre, no other factor. So we have to understand what's going on there. Ideal population to real population, so I mentioned that earlier. How do we move from that idealised view from a randomised controlled trial into real life, and how we account for multimorbidity and the messiness of real life to make sure that we get the best outcomes for patients, and therefore lead to personalised care from that generalised care that I spoke about earlier, and focusing on meeting true need and using the data to help us do that. So I've come to the end of my presentation now. I hope that we've got some time for questions. I think we've got about 10 minutes or so, so I'm very happy to answer any questions you may have. Thank you.
Thank you, Sally. That's been fantastic. So if anyone does have a question, you can type it in the Q&A section. Just at the bottom of your screen, you should see a little Q&A, and you can ask any questions away. So we'll just give people a moment to ask a question. In the meantime, I'll ask Sally, What would you say when you approached this you thought might be your biggest roadblocks, and has that proved to be correct, or has there been some surprises?
Yes, so I think I thought that one of the biggest barriers would be that clinicians and patients would not be engaged with this, and that hasn't been the case at all. I knew that IT would be a barrier, and it was, and we're working through that, but it continues to be a challenge, but we now have managed to, through some early successes, really develop a very effective national collaboration with the Welsh Informatics Service and the finance community, and that collaborative approach from the multidisciplinary team is absolutely vital to overcoming some of that. I think I've got a question.
You do. So the question you've got is, in the NDR, are there standard quality of life outcome measures that will be collected? Yes,
thanks, Alyssa. That's a great question. So the way that works is that the data set that's going to be collected will be defined and standardized by the clinical network for that particular condition. So the cardiology network will tell us what the data set is and the PROM tools that they would want to use. We then sort out Welsh translation and licensing across Wales so that we have that common data set. Absolutely, yeah.
We have another question. Someone's asking that they're interested in how you ensure the quality of your outcome data collection. Many stakeholders in the Australian healthcare system don't trust the quality of this type of real-world data collection, and therefore it's often not used in decision making.
Yeah, absolutely. So I think there's two issues about quality of the data. One is incomplete data, obviously, and that's probably one of the biggest issues that you'll experience with PROM data. And the other criticism of PROM data I've heard is its reliability, reproducibility, and so on. But I think if we acknowledge both of those with those caveats, we can still make very good use of this data. In terms of ensuring the quality and integrity of the outcome data collection, there's a lot of work going on around data standards within the National Welsh Informatics Service, and I also do have access to a very small research unit. So if we were going to do a deeper analysis, let's say a cost effectiveness analysis using real world data, and we're not quite there yet, we don't quite have enough data to do this yet. We have access to a small research unit so that we can make sure that any statistical analyses do have any of those caveats built in, so we make absolutely sure that we're not drawing erroneous conclusions from the data. But the other thing I would say for those who don't trust this data is that all data has issues, but we do need to start to draw some insights that come directly from patients. So we just need to be awake to the fact that this data, as any other data, has some limitations. But thanks for the question. It's a great question.
We've got two questions, I think, that speak to general practice and primary care. So a question around how you've gone about engaging general practice and primary care in this work, and another about the approach in the community practice, keeping patients in their home and monitoring them with outcome measurements.
Yes. Well, so primary care has come in second. So we definitely started in the hospital, which was weird for me because I'm a GP. But it started in the hospital because actually our hospital systems were much less developed than our GP systems in terms of informatics. So they really needed to sort of come up to general practice standards in terms of data. And and I needed to get the secondary care clinicians very, very much on board. So now primary care are coming in alongside this and starting to use quality of life measures, for example, to look at MDT interventions and social prescribing, that kind of thing in the community. So there's some interesting work developing there. I think, where do I see the value of this in community practice? Well, I mentioned the heart failure example, so I'll go back to that one. I think that using that self-tracker and that remote collection, we can start to understand who is stable and who is not. That means we can flex our resources so that we can get in there and provide more intense face-to-face intervention for those who have greater need, but be a bit more hands-off with the people that are stable. And I think that approach extrapolates across to lots of patients with multi-morbidity in the community. The other surprising thing, which I could have answered to your first question, Lisa, was we expected that there would be much more difficulty for older people using smartphone technology, for example, than actually was the case, and that increasingly there's just quite a small percentage of people that are digitally excluded. Now that's interesting because where my practice is, the region where my practice is was recently classified as one of the most digitally excluded populations in Europe. So we're not talking about a privileged population here. So you can overcome some of these barriers. Now I know that I suspect in Australia that you will have some rather particular technological issues and coverage issues, I would expect. But I think you can, if you adopt a problem-solving approach and realise you're not going to solve everything overnight, you can start to work through some of these things.
Fantastic. One more question. Paula Conroy has said that she's a GP working in a hospital and healthcare system and is wondering how you went about achieving widespread cultural change within your network, specifically around getting GPs in the hospital system to work together.
Yeah. The way we do this in Wales is that we have clusters of GPs, which I think you have primary healthcare networks in Victoria, and
they're nationwide.
Are they nationwide? Yeah. So we have they're not exactly the same in Wales, but we have a way of primary care collaborating and communicating with each other. Now, the health boards are integrated health boards that manage all services, including mental health and all community services and all of the hospitals. So it's quite easy to bring people together. And for example, in the COPD project that I spoke about, we had primary care physicians and respiratory physicians around the table, and getting people thinking together around a common aim where they can start to be empowered and have influence, for example, about where they can direct resource within the system, really started to unlock that relationship and develop that relationship of mutual respect. The other tactic definitely is where there is where that relationship is not great, perhaps between primary and secondary care. If you bring patients into the room, that changes the dynamic significantly and often enables you to move that conversation on much more quickly. So it depends on the context really, but I think it's necessary to spend lots and lots and lots of time on cultural change, and that means lots of conversations. I'm in my car constantly, driving around, and so are my colleagues now, meeting as many. It's everything from a corridor conversation to a bigger meeting, you know, piggybacking on CPD, every which way you can think of, because at the beginning you don't have any resource. So I didn't have any resource at the beginning either, and you have to create the momentum around this exciting work before you have that resource, and then you'll find that you start to see results and things that you can start to persuade other people within the system to get the policy to come in and support you, and get resources to help you do the informatics development and so on. But spending a lot of thought around what we're trying to achieve here. This is not about driving the medical industrial complex or getting a pharma company to adopt a new drug because it's got marginally better outcomes than the other one. That's not what it's about. It's about empowering the people who know what needs to happen intuitively and giving them the tools to do that, one of which is data and the other is some influence over how a resource is allocated across the system. And that, I think, can apply no matter what your funding mechanisms are. So you'll have different barriers than to us, for sure. There'll be slightly different challenges there. But that doesn't mean that you can't adopt the same principles and use them as problem-solving tools, if that makes sense.
Yeah, that's great. Thank you so much. So thanks for a fantastic presentation, Sally. We actually hold webinars on topics related to value-based healthcare each month, but in November we have a second webinar. In 2 weeks' time we'll be presenting Dr. Carlos Francisco Silva, a Portuguese board-certified radiologist, and he's going to be presenting on a practical approach to value-based radiology. However, you don't need to be a radiologist to join this webinar. He's going to be discussing a range of concepts with broad application across the health system, including how to identify value in the field of medicine, the problems of waste, and practical examples of valuable reports. I'm sure they'll build on some of the ones that Sally has talked about today. Our December webinar will be another practically focused topic with a discussion on outcomes-based commissioning as it relates to diabetes. So registration is open now for both of those webinars and they're available on our website. I'd like to once again extend our sincere thanks to Dr. Sally Lewis for taking time out during her visit to Australia to present to us and hope that everyone has a great rest of their day. Thank you.
Thanks everyone, bye.